So it's my real pleasure to introduce the moderator of this session, Dr. Simon Beaven. Simon is the Research and Medical Director of our Center for Obesity and Metabolic Health here at UCLA. And I'll have Simon, he'll be giving the first talk and introducing the rest of the panel. Simon?
All right, well, welcome. Congratulations on making it to the end of the symposium. I'm very pleased to bring to you Metabolic Disorders 2016. So at UCLA, we have an interdisciplinary venture between medical doctors, surgeons, psychologists, nutritionists, research scientists, and it's called the Center for Obesity and Metabolic Health. And I'm the medical and research director. So my talk is loosely entitled Management of NASH, but I'm really talking about the metabolic syndrome. I have no financial relationships. Of course, I'm talking about investigational drug use because that's really all we have in terms of the medical therapy for obesity and fatty liver. My plan today is to give you an update on the genetics and pathogenesis of NASH, and then, hey, what's new? What's new in treating it? This is not in your syllabus, but I want to take you back to the heady days of the early 1990s when the metabolic syndrome had not crossed the major radars yet. And here we have, I'm sure you recognize them, the new kids on the block. And even then, Mr. Wahlberg there on the right was prescient because he understood that drug treatment for obesity or fatty liver, it sucks. It's just not good. And I've given this type of talk probably 8 years in a row in different venues, and there are mild variations. But this is a year where I think there's some really exciting stuff coming out that I want to share with you. Worldview of the hepatologist shows a progression from normal liver through injured liver to fibrosis and cirrhosis. And you can see here by the thickness of this arrow that we generally think that the progression is towards cirrhosis, and the question of whether you can revert from a cirrhotic state to a subcirrhotic state is still an open question because all the bad outcomes in liver disease happen based largely on cirrhosis. And that's even more important in the world of NAFLD and NASH. So fatty liver by itself or fatty liver with significant inflammation and then scarring in the liver. So obese Ronald McDonald is wondering, wow, can I actually reverse the course of time? I want you to remember that the liver is a central part of the metabolic syndrome. You know that it's composed of obesity and diabetes, cardiovascular disease, and cholesterol dysfunction, but fatty liver is right in the middle there. And underpinning this collection of different disorders is really insulin resistance. And for the past 30 to 40 years, people have been battling with this yin and yang model of, is it the metabolism or is it the inflammation? And I'll tell you, the reason I put metabolism on the top is not because I'm a metabolic researcher, which I am, but it's turning out that these are the avenues that really need to be pressed on, more so than inflammation, and that we may have been not misled, but sort of misguided in our emphasis of using anti-inflammatory approaches as the primary way to treat obesity and fatty liver. So what do I mean by that? So to understand the metabolic syndrome, you have to understand that your body contains receptors that are endogenous nutrient receptors. You have ones for bile acids, fatty acids, and cholesterol. And I realize it looks a little bit like alphabet soup, and they all have different names, FXRs, PPARs, and LXRs. But each of these receptors, they're all related. They're all cousins. They act as a receptor because they have a ligand, such as bile acids. And they act as a transcription factor because they're already in the nucleus of cells. And what makes them special is the tissue distribution. Depending where they are and when the ligand comes to meet it, that's when you get the magic happens. Over the last 2 decades, Big Pharma has been very interested in these receptors, and there are lots of agonists and antagonists, but in general, these receptors sit on top of a very broad program of gene expression across a lot of tissues. So the agonists, while they have some beneficial effects, tend to have crossover or side effects that you don't want. And we're now in a new era where we realize that it's not the receptors themselves, but perhaps hormones just underneath them, in this case FGF15 or 19, or in the case of PPARs, FGF21. These circulating hormones, which act as endocrine agents, really are the key feature. Such a thing has not been yet discovered for LXRs. This is the one I happen to study, so we're very interested in looking at that. By the way, FGF 15/19 was the first demonstration that the intestine acts as an endocrine organ, because when bile acids reach the terminal ileum, they tickle the epithelial cells to secrete this hormone, which then goes back to the liver and change gene expression to alter the flow of bile. So it's a very tightly regulated system. And I'm going to tell you a lot more about FGF21 in this talk. You probably know this already. There's lots of changes that happen in NASH. You get fatty liver because there's more lipid being delivered to it, either from the diet or from the adipose tissue. The liver itself can make fat. That's called de novo lipogenesis. It's under the control of that cholesterol receptor I just told you about. Or you can burn fat in the liver by ramping up beta oxidation of fatty acids. And when you turn that down, you're going to have fatty liver. That's under the control of another nuclear receptor, one of the PPARs, which is really a fibrate target. You know that lipids impair hepatic insulin signaling. That leads to hepatic insulin resistance, diabetes. There are also pathways where increased inflammation, oxidation, ER stress, and autophagy may be important. Our laboratory a couple of years ago demonstrated that there is a hormonal relationship between the liver and the fat, which was previously unsuspected, and showed that you could have an massively obese state with lots of inflammation and yet still be supremely insulin sensitive. And so we are working hard to understand the mechanisms of that now and to identify the soluble mediator or hormone that does that. I'm going to jump gears to the genetics in NASH because it's the least understood. In our hepatology world, we are behind the times in terms of GWAS studies. But I will show you, this is older data from Helen Hobbs's group and others, that genetic variation in PNPLA3, which is a patatin-like phospholipase, if you happen to have the GG variant, single change in a nucleotide, if you're the GG variant, whether you're European American, African American, or Hispanic, you have a higher hepatic triglyceride content than people that are either heterozygotes or have the homozygous CC genotype. And that may actually help explain why we see a larger proportion of Hispanics with fatty liver disease and NASH as compared to African Americans. I want to point out that this gene is a metabolic gene. It's a phospholipase, okay? Here's another metabolic gene, ApoC3, variation in which predicts the presence of fatty liver both in hepatic triglyceride percentage and in plasma triglycerides. This was in particular in subcontinental Indian men, but it was a pretty profound difference. Most people do not have this variant in ApoC3, but again, the genetics are pointing not to inflammatory genes, but to genes that are involved in lipoprotein metabolism or phospholipid cleavage. So here's some of the new stuff. This is a reminder that I get to watch Game of Thrones when it comes back on in April. This is, of course, Khaleesi, the mother of dragons. And I bring this up because what I want to talk to you about is something equally as exciting. It's the mother of fats. When you were in medical school, or maybe just out of it, you probably heard that there was a fat precursor cell. And for a long time, we've thought that white fat, the adipose tissue around your waist or around your inner organs, comes from a fat precursor. And that brown fat cells that are supposed to regulate thermogenesis and are present largely in hibernating mammals and maybe in the subscapular tissue of babies, we thought they came from the same thing because this PPAR gamma, which is one of those nuclear receptors, is the master regulator for the development of these adipocytes. Well, that's not true. And I'll show you that in a second. First of all, adult humans have brown fat. You can find small deposits of brown fat, thermogenic material, in the sternoclavicular region, around the costochondral junctions, and it's present in adult humans as well as in younger folks. The new paradigm is that brown fat and white fat are actually brothers from a different mother. In this case, it's a muscle cell precursor that develops into brown fat or muscle. And it's the discovery of a second transcription factor, this one here, that regulates that. So there's a lot of excitement about whether or not you could actually turn white fat into brown, that's called beiging, and whether you could develop pharmaceutical targets that do that, because that would be a nice way to burn fat. And I'll tell you, there's emerging data of all the things in the medical world that don't work, it's drugs for obesity. The one thing that works really well to cause you to lose weight is cancer. And it turns out the process of cachexia may in fact do exactly this, turn adipose tissue into a thermogenic, beige-like fat to burn energy stores. And as of 4 days ago, there's been a slew of papers in the last 2 months showing that that soluble factor I showed you earlier, FGF21, may actually help mediate that partition between white and brown and beige fat. Part of that work shows that the liver actually makes FGF21 and that it circulates up to the brain, crosses the blood-brain barrier, and suppresses your preference for not only sweet, but for alcohol. It doesn't do anything to bitter taste, and it does not work on the taste receptor cells. It doesn't work on the enteroendocrine cells. So this is a hallmark year. Just as leptin was the first adipokine to be shown that comes from fat and travels to the brain that changes behavior, this is the first time that a soluble endocrine factor has been shown to come from the liver specifically to alter behavior. We've been looking for one for a long time, so it's a little surprising we haven't seen that earlier. So even better, there are FGF21 analogs not only in research labs, but in clinical trials. And this study, also in the same issue of cell metabolism, shows the results of giving this FGF21 long-acting agonist to fat monkeys and fat humans. And you can see that it actually causes body weight loss, decreases food intake in the monkeys. It wasn't well studied in the humans. We don't know yet. It causes a decrease in triglycerides, and yet doesn't seem to have any effect on glycemic control, showing that this pathway separates the obese state from the hyperglycemic state. Now, whether there are changes in the mineral content of bone in the long run remain to be seen, but it's a very exciting study. So what are the treatments for NASH? Well, this list gets modified year after year. My favorite is the one at the top, diet, exercise, sleep, and alcohol reduction. That's a no-brainer. All the drugs here, well, Meridia got taken off the market. It was basically a speed amphetamine derivative, and it had the expected side effects and cardiovascular problems. But all these other ones why don't we use them that much? It's because they have limited efficacy. Plus, they have a lot of side effects. Bariatric surgery is a great option for the right candidate, or endoscopic therapy, and you're going to be hearing about those subjects from my co-speakers. The ones in stars are the drugs that have been tried in the treatment specifically of NASH that have been shown to have at least some efficacy. And you can see, why did I show you all that basic science stuff about nuclear receptors? Because it's all over here. Glitazones are PPAR gamma agonists. Fibrates are PPAR agonists. The new one, obeticholic acid, you've probably heard about, is an FXR agonist. Pentoxifylline and vitamin E are essentially sort of anti-inflammatory antioxidants. But I think you're probably aware of all this stuff, and maybe also aware that we're using GLP-1 inhibitors, liraglutide or Saxenda, to try and treat obesity. But this drug, like these others, has a limited efficacy. This is just to remind you that glitazones are drugs that activate PPAR gamma, but the effect is not in the liver, it's actually in the fat. They're insulin sensitizers. They basically mimic the action of insulin, and they cause increased triglyceride storage. So just remember, if you're using glitazone for NASH, you're only really secondarily treating the liver. You're treating the diabetic state. You're treating the fat. Here is a summary of the drug effects that are known to this point in NASH. And you have to realize the longest human trial with any compound in fatty liver is 2 years. It's really a very short time. And you can see here, all the blue bars are the placebo effect, the dark blue bars. And you can see vitamin E in red and pioglitazone, that PPAR gamma agonist, in green, and also that new drug, obeticholic acid, which is an FXR agonist. And you can see little stars here showing that there is, in fact, a significant increase in improvement in terms of steatosis, lobular inflammation, hepatocyte ballooning, maybe not fibrosis here, but obeticholic acid showed an increase, NASH resolution, and primary outcome. And I've listed for you the primary outcomes of these trials because that's important. They are essentially tissue histologic improvements, not necessarily true long-term clinical outcomes, and that's the problem. So despite all the hullabaloo, we've been waiting for this obeticholic acid for a couple of years. It took them a long time to publish it, and there's a reason. Even though it was a very well-designed, double-blind, randomized control trial in patients with biopsy-proven NASH who were not cirrhotic and half of whom were diabetic, what they could conclude, and these are the author's own words, obeticholic acid improved the histologic features of NASH, but its long-term benefits and safety need further clarification. But wait a minute, Dr. Beaven, you just told me it improved fibrosis. Isn't that what you care about as a hepatologist? Well, it turns out the complete resolution of NASH did not differ between the placebo or the treated group. The liver function test improved during treatment, but not after, which means this is a drug you're going to have to give every day for the rest of their life. Yes, fibrosis improved. It was a difference of 0.2 versus 0.1. And that's measured on a really crummy type of scoring system, which is stage 0, 1, 2, 3, or 4. I don't even know what that means, because we don't stage liver disease as a 2.3. So I think it's a little bit disingenuous to say this is a marked improvement in fibrosis, even if you get to put a statistical star on it. They also kind of downplayed the fact that there was an increased LDL level and a decreased HDL level. They actually underestimated because they didn't count the people that stopped taking the drug during the trial. Worst of all, about a quarter of people got really intractable pruritus. You got to remember, obeticholic acid is a bile acid analog, so if things get gummed up, then maybe that's the result. And there were some nastier outcomes as well. So quite honestly, obeticholic acid is no better than vitamin E or pioglitazone, and it's a sure lot more expensive. That brings us to the new era, okay? And of course, you recognize this as One Dimension. Oh, no, One Direction, sorry. The new British boy band. And I invite you to go look up New Kids on the Block, because they have been subjected to the same ravages that the rest of us have over the last 30 years. Age and time and excess nutrient, and in their case probably a lot of money, add up to a little extra weight gain, and maybe they're struggling with the same things most of your patients are. These guys, of course, are only 18. So the emerging treatments for NASH are FGF21, which, as I just showed you, there's the monkey trial and some human data, but the true randomized control trial in humans hasn't happened yet. But there's good reason to believe, for all those scientific reasons I mentioned, that this is going to be a hormonal variant that really helps you suppress liver fat, increases beta oxidation, and may actually alter central nervous system and behavioral patterns. I like that one. The exenatide and liraglutide GLP-1 agonists, they do improve liver histology, again, marginal effects on fibrosis, and the preliminary results in human studies are meh, not so great. This is the GenFit, French company's PPAR alpha/delta dual agonist. The Golden trial is supposed to be done, and we saw preliminary data at the American Association for the Study of Liver Diseases meeting this fall. It has about the same effects as pioglitazone and vitamin E, but it doesn't have a lot of the downside effects, but we're waiting to see that in publication. These other ones are all ongoing in human trials, and some of them are promoted. This is one that's directly targeting the fibrosis process. Here's another approach that's tackling another metabolic pathway in fat synthesis. This one is going to be an anti-inflammatory. My prediction is it's not going to have a great effect. So why do we care about this? Because the outcomes of NASH are horrible. If you consider, and I should probably update it, I think it's 330 million. If you think at least a third of the country has just fatty liver, and maybe 5 to 17% have actual NASH, and even if you're super conservative and go with autopsy-based data and say, oh, it's only 1% of the population has NASH, you're still talking about a lot of people. And there's the most conservative NASH prevalence, and here's the one that most people accept, which is 5%. And as you walk down this list, you can see the burden of disease from both cirrhosis, liver-related death, and HCC is horrific. Fatty liver and NASH is the only increasing indication for liver transplant. Hep C, PSC, all these other things are going down. Alcoholic liver disease will probably be the same for the rest of our natural histories. That's a very difficult one to change. Although, like I said, if FGF21 alters preference for alcohol, that might represent a novel targeting pathway for addiction medicine. The real scary thing is the elephant in the room, which is liver cancer in the setting of a non-cirrhotic liver. In fact, my colleague, Dr. Dutson, who's going to speak next, he and I were discussing a case of a woman who he found what looks like an HCC, and there was no suspicion of cirrhosis and a normal-looking liver at the time of bariatric surgery. So this is really a scary moment. In summary, NAFLD is like a benign little brownie. Probably nothing bad will happen to you if you just have some fat in your liver and you go through your life that way. But if you have an angry hobgoblin and you've got fat plus inflammation, that's when bad things start to happen and you get progression. So it's a combination between studying the basic pathways and the genetics that we're going to understand how to treat this. Metabolism, that's my emphasis to you today. Metabolism is the key driver of NASH. The genetic evidence I showed you and the currently popular drug targets that pharmaceutical companies buy really show that, not the inflammatory pathways. There are still no great medical therapies for NASH, so the new kids on the block in one direction, they're going to have to wait. Maybe the next boy band will benefit from it. And this is a segue because I think bariatric surgery and endoscopic approaches to obesity really are what we should be doing when at all possible. And the reason is because the outcomes of NASH are just ominous. So thank you for your attention.